Thank you for coming. Thank you for listening to us talk about sleep apnea. People always wonder why a cardiologist is talking about sleep apnea, and I also wonder about that myself sometimes, but this is sort of the continuum for what we talked about with how the altitude affects your heart. And I would say out of my experience of being up there in the last 3 years and training at sea level, discovering the effects of sleep apnea on the cardiovascular system has been one of the biggest lessons that we as a staff have had to conquer. And hopefully tonight I can go through some of the sleep apnea, how the altitude affects it, and what the cardiovascular side effects are, so everyone has a better understanding of this condition. So as sort of an agenda, I want to start off and say, what is sleep apnea? What is this misnomer? What is this diagnosis? And who's affected? We're going to talk about the symptoms, briefly how is it treated, how does the altitude affect it, and we're also going to talk about, from my standpoint, what are the cardiovascular conditions that I see as a consequence of it. If any of you can't see, there's some slides that have some smaller details on it. You're more than welcome to sit up front here if it gets too blurry or you can't see in the back. So this is what I always thought of as sleep apnea, was the big obese male that was snoring so loud that everyone wanted to throw something at him at night, and the wife would set him to the couch. And I couldn't have been wronger, okay? Because although this is how it's classically described, I would say the vast majority of patients I see with sleep apnea are thin and usually healthy people. So forget this, it's wrong. It's not a correct stereotype. So when we talk about sleep apnea, it really falls under an umbrella of sleep disordered breathing. So there are all kinds of problems that can occur when you sleep at night. And breathing abnormalities are just one of them. There's conditions where you can move your legs all night which disturb your sleep. But for tonight, for purposes, I'm going to talk about sleep apnea. So what is sleep apnea? Well, sleep apnea is a disruption in your ventilation or your breathing at night. And it usually occurs with a problem in the pharynx, which is a region right here in your throat. And it'll obstruct when you sleep, and I'll show you how that happens. So if you obstruct your airway during the night, and that obstruction lasts for at least 10 seconds, we call that an apnea, which means without breath. If you slow down your breathing, usually to less than 50% of the baseline for 10 seconds, and that's associated with a drop in your oxygen saturation, we call that a hypopnea. So the breathing abnormalities at night are a function of your apnea, which means you stop breathing, and your hypopnea, which are the slower breaths. Everyone does it. A normal person does it. But you should only do it up to 5 times an hour. Okay, the sum of the apneas and the hypopneas should be less than 5 times an hour per hour slept. Mildly abnormal would be 5 to 15 times an hour. Moderately abnormal, 15 to 30. And universally, if you're doing this more than 30 times an hour, you have severe sleep apnea. Well, what is the pharynx? Well, this is sort of a cross-section if you'll take of the human face. And so you see up top here, this is the nasal cavity, which leads back into the nasal pharynx. And then you have your hard palate, which is sort of the roof of your mouth, back to the soft palate, your tongue. And in the back here is the oropharynx, sort of an airway. And down below here is the laryngopharynx, which is next to your airway. The pharynx itself is a incredibly complex structure. And I don't expect you to memorize all the muscles, but what you need to know is that there's all kinds of muscles that surround this airway, which are involved in speech, involved in swallowing, and involved in breathing. So what happens to the pharynx in sleep apnea patients? Almost everyone has some type of abnormality of the pharynx and that the airway is too small. And this could be because you're overweight and there's too much soft tissue around the neck, so it puts extrinsic pressure on the airway. It can be a congenital abnormality. Maybe you're someone that has a setback chin, which narrows the airway. Maybe you're someone that has too big a tongue, so it falls back and compresses the airway. You could be someone that never had your tonsils taken out or your adenoids, so you have extra tissue which compresses the airway in the back. But almost universally, there's some abnormality of the airway which leads to the apnea. Now, I get this question all the time. It's like, well, doctor, my oxygen saturation's fine right now. What are you talking about? I'm sitting here talking to you. I'm 95%. I don't have a problem with my breathing. And it's really interesting. So if you have this small airway, you have these receptors down in your larynx that know your airway's small. And they compensate by that by stimulating muscles in the pharynx to dilate the airway. So when you're awake, they're maximally stimulating these dilatory muscles, and you're breathing just fine. But when you go to sleep, particularly when you drift down into lower levels of sleep, the neural impulses to those muscles start to drop off. And the airway gets softer and more relaxed because it's not dilating. It gets narrower and narrower. And then when you go to take in that deep breath, it's like sucking through a floppy straw. It just collapses and closes and causes the apnea. So here's a scheme of how that happens. A normal person on the left, again, here's the portion of the pharynx back here, breathing normally, open airway. Muscle tone's lost, airway starts to collapse, tongue falls back, you obstruct the airway, and there's your apnea. So what happens? Well, you get stuck in this vicious cycle, this repetitive cycle. So you go to sleep, you fall asleep, your upper airway starts to relax, and you start snoring. And this snoring is a sign that the air is vibrating through your airway. It's starting to collapse, it's starting to get more narrow, it's getting floppier, and it's starting to vibrate as you breathe. You keep relaxing the airway, and eventually the airway obstructs, and you stop breathing. That's the apnea, 10 seconds. You don't breathe, your oxygen levels fall. Once your oxygen levels fall, your brain freaks out. It's not normal. There's no oxygen going to the brain. So it wakes you up. And everyone says, well, I don't wake up. I go to bed at 9 o'clock, I get up at 7, I feel fine. What are you talking about? Well, some people don't wake up all the way. In the worst cases, you may jump out of bed, choke, gasp, roll over, and go back to sleep. But sometimes it just wakes you up enough to your brain to wake up to say, hey, I gotta open those muscles. I gotta stimulate those dilator muscles to open the airway back up. And that could be happening 15, 20 times an hour. So your sleep is fragmented, but you're not waking up enough to know what's going on. But then you wake up, you open up the airway, you go back to sleep, the whole process repeats itself. That's the vicious cycle you get stuck. Well, how does that affect your heart? A number of ways. The first response when you close your airway is you activate a part of your nervous system called your sympathetic nervous system. So you know when you get really scared, like someone makes a loud sound or something startles you and you get that burst of adrenaline, that's your sympathetic nervous system being activated. And that's hormones, these catecholamine hormones that do that. Well, what that does is it constricts your blood vessels and skyrockets your blood pressure. So blood pressures have been documented as high as 240 over 130 during periods of apnea. You also get all kinds of hormone release. You get this molecule called endothelin, which is released, which is they think is part of the vasoconstriction. You also get a hormone called aldosterone released, which is on your adrenal gland and your kidney, which causes you to retain sodium and to elevate your blood pressure. You get this huge state of inflammation from the low oxygen. So many of you may have like what's called a CRP test done to sort of screen for heart disease. People with sleep apnea have higher CRP levels related to the inflammation from the apnea. the blood vessel itself, so blood vessels aren't just a tube. They don't just carry blood. They have cells, dynamic structures, and this includes hormones, which regulates how much they dilate, how much they constrict. And that whole process becomes abnormal from the repetitive oxygen. They lose the ability to sort of regulate their own little structure there. You get insulin resistance. So their diabetes goes out of whack, and people find it really hard to lose weight. It's so difficult for people to lose weight when their sleep apnea is untreated. You're prone to clots. So your blood wants to clot. And that's what a heart attack or a stroke is. That's a blood clot that occurs in your arteries. So you're putting yourself in this inflammatory pro-thrombotic or pro-clotting state. And just the pressure change. So imagine like trying to suck in against, sticking your thumb in your mouth and trying to suck in against that. You create this huge negative pressure in your chest. And that negative pressure transmits to the organs. So it can enlarge your aorta, the main blood vessel in your body. It can enlarge chambers in your heart. It can cause thickness of your heart muscle, which leads to other cardiovascular conditions down the road. So what are the symptoms? I will say these are all over the map. I have seen people that are totally asymptomatic with severe apnea. I've seen people severely symptomatic with mild apnea. This is traditionally what's explained. So we take the process over, you stop breathing, you start snoring. Okay, so snoring is probably the most common symptom that's noted. Everyone who snores, most people with sleep apnea snore, but not everyone who snores has sleep apnea. There are some other conditions that can cause snoring which are not related to sleep apnea. But if you have a spouse that snores, good idea to get them checked. So if you snore and you're vibrating air, you get a dry mouth. Okay, you wake up in the morning, your mouth just feels really dry. You can have a sore throat. You can have a headache in the morning. Memory loss. You don't get oxygen to your brain all night. So people feel fuzzy. They're not as sharp. They can't remember things. They're just sort of off. Their brain doesn't feel like what it should be. They can't concentrate. So you have a hard time doing stuff during the day, trying to concentrate on tasks. Car accidents. Okay, that's not up there, but people, you don't sleep all night. You're tired. So people get in accidents because they fall asleep at stoplights when they're pausing. Frequently I'll ask people, if you sit down to read a book or watch a TV show at 3 o'clock in the afternoon, are you out by the light? And the people that say yes, very high probability there's sleep apnea that's causing it. Depression. I don't know how many people have come to me on depression medications, and when we treated their sleep apnea, they've gotten off. Because you start getting oxygen to your brain at night, it does crazy things. Tired, fatigued, peeing at night. So people get up at night and they say, well, that's my prostate. I have a bad prostate. Well, that's not always right. Sometimes the sleep apnea causes that, and you treat the apnea, and you don't have to get up all night to pee. Sexual dysfunction, and of course, all kinds of problems just maintaining a regular sleep pattern. So who's really at risk for this? Well, again, traditionally, it gets worse as you get older. It usually occurs in men more than women. Obesity, of course, okay? That's the #1 risk factor. Neck circumference is another one. If you have a neck circumference greater than 17 inches, that's considered a risk factor for sleep apnea as well. I will tell you, in my experience here in the altitude, people that take long-acting narcotics, things like MS-Contin, methadone for chronic pain, that interferes with your respiratory drive, which can also trigger another form of sleep apnea. So I see that pretty frequently. If you're a drinker, if you're a heavy drinker, alcohol suppresses your respiratory drive, suppresses your brain, makes it easier for the airway to collapse and trigger the apnea. In my world, these are the people from cardiovascular disease that I really look for the sleep apnea. If you have congestive heart failure, if you have resistant hypertension, which means you're on 3 or more medications and we can't get your blood pressure controlled. If you get chest pain at night from the low oxygen levels dropping, insufficient oxygen to your heart muscle causing pain that wakes you up at night, strong clue to me for sleep apnea. And anyone who complains about arrhythmias at night, palpitations, fluttering in their chest, disturbances that wake them up at night, I always screen them for sleep apnea as well. So how do we diagnose this? Well, it's almost borderline torture, to be honest with you. It's, those of you that go through it, it's called a polysomnogram, is the diagnostic test, which is done at Barton. I think they have 2 going on 3 sleep labs that are functioning now. And it's a very detailed and comprehensive test. This is the gold standard to diagnose the disorder. And it's a ton of electrodes. So they have electrodes on your scalp, which measure your brainwave activity, which tell us which level of sleep you're in. They have measures on your eyes, on the outside of your eyes, to measure your eye movements, to know if you're in REM sleep or non-REM sleep. They have muscle electrodes. They have an EKG. They have oxygen flow sensors. They have chest straps. They have a video camera on you. All of this is used to diagnose how bad your sleep apnea is and what type of apnea it is. There are 2 main forms. Well, not everyone's okay with that when I go through it with them, and they say, gosh, that really sounds bad. I don't know if I want to do that. There are a number of companies that make a home sleep study. The advantage of the home sleep study is, of course, you get to do it at home. It's not as invasive. You don't have as many electrodes on you. This is the one we commonly use in our office. It's by a company called Novasong. It has, and I actually did one to check it out. It wasn't that bad. You have an armband that goes around here with a unit. You have a pulse oximeter, which measures your oxygen and pulse rate. You have a chest strap, which measures chest expansion, and a little oxygen cannula that detects flow. The disadvantage to this is it can't detect a lot of the respiratory abnormalities related to altitude, the so-called central sleep apnea. That can only be done in a sleep lab. And you just don't get as much information. You get some of it, but you don't get all of it. So I will use this in people who I'm just screening for apnea. Maybe they have some palpitations. But if you've had a heart attack, you've had a stroke, you have COPD, you're on oxygen, any compromise of your neurologic or respiratory status, this is probably not the right test for you, and you should have the inpatient procedure or the in-house study performed. The last screening test you can use is called an overnight pulse oximeter. This just gives you 2 pieces of information, your oxygen saturation and your pulse rate. Well, most of the oxygen companies deliver them, very easy to wear, and is a sort of a cheap screening test that you can do to sort of just determine whether there's an oxygen problem at night. Well, how do you treat it? The treatment is called CPAP, which stands for continuous positive airway pressure. So if the anatomical abnormality is that the pharynx is collapsing at night, well, you want to keep it open. So you blow in air with this CPAP machine, which pneumatically splints open the pharynx and prevents it from collapsing. So that way you can breathe in and out through a patent airway. This is the hardest part about the apnea, is getting people used to the CPAP and on the CPAP. We have over 400 masks that are available to use. There are numerous pressure settings to get people to get comfortable with the CPAP. Only 50% of the people stick with it. It's not a normal thing to wear a mask at night when you sleep. It usually takes people anywhere from 3 to 6 months, in my sort of anecdotal experience, to get used to the machine, on the machine, sleep comfortably with it, and start to reap the benefits. Some people come out of the sleep study where they get fitted for the CPAP and say, best night's sleep I've had in 10 years, give me that machine tomorrow. Most people, I got to battle them a little bit. But the people that stick with it, very few of them 6 months later say, yeah, it's not doing anything for me. The masks, like I said, all kinds. The main ones that we use are either what we say a full face mask, so it covers your nose and mouth if you're a mouth breather at night. Sometimes we have ones that just go over the nose. Sometimes they just go into the nose. That's all accomplished in what's called your titration study, where you spend a whole night just getting fitted for the mask and getting the pressures right. And even if it's not the first mask is usually not the right one, it takes a couple times, but the oxygen companies will work with you to get you the right mask, which is critically important. There are other treatment options. Of course, weight loss helps. You remove the extrinsic compression on the pharynx, improves the apnea. Sleeping on your side, apnea is always worse on your back. So sometimes you've heard about like the wife sewing a tennis ball into the guy's shirt so he won't roll over onto his back. That's commonly used to get him on the side. Cut down your alcohol, that's an easy one to do. There are all kinds of oral appliances that dentists can make to shift forward the mandible to try and alleviate the obstruction. There is surgical techniques that are used to reconstruct the throat, to remove some of the tissue in the throat to allow a bigger airway. But by far and away, the CPAP therapy is the gold standard for treatment. So what about altitude? So that's sleep apnea. That's great. Probably can figure it out, probably can diagnose it, you know how to treat it. Well, what about you guys that live at 6,500 feet or higher? Well, it makes it more complex. And the reason it's more complex is you have a different environment here than people at sea level. And that's directly related to the lower atmospheric pressure. The amount of oxygen, the percent of oxygen in the air never changes. It's always stable at 21%. But the atmospheric pressure as you go higher and higher gets lower, and hence there's less air. And you can see compared to sea level here, by the time you hit lake level, lower atmospheric pressure. By the time you're on top of Kingsbury Grade, even lower atmospheric pressure and less oxygen. So there's less air here. There's about 2/3 as much air here as there is in the Bay Area. Well, how does your body regulate that? Well, it's really complex. You have receptors, more receptors in your bloodstream that detect how much oxygen's in your blood. And if you don't get enough oxygen, your body doesn't like that. It sends signals up to your brain and then signals down to your lung to say, hey, you gotta breathe more, I need more oxygen. And we call that acclimatization to the high altitude. So the first thing you do is you breathe deeper and you breathe faster because you gotta get more air into your body. So people that may come visit you from the Bay Area may say, God, I just feel short of breath. And that's normal. They're trying to acclimate and breathe faster and harder to the lower oxygen up here. Well, that's not always such a good thing because as you breathe faster and deeper, you get more oxygen, but you blow out all your carbon dioxide. And when you blow out all your carbon dioxide, it affects the acid-base balance of your body. So you get what's called an alkalosis, meaning your pH of your body rises because you're blowing out all the carbon dioxide. I always laugh because everything I read about high altitude says, you come up to high altitude, you should take it easy for 2 days to let your body acclimate, drink a lot of water, and don't drink any alcohol. And I don't know anyone that comes up here and does that. So if you have company that comes and they say, God, I slept terrible last night, I got this headache, I feel, just take it easy for the first couple days, drink a lot of water. After 48 hours or so, they'll probably acclimate and be ready to go off and take off the slopes. Now, if you keep going up in altitude, or if there's problems with that acclimatization, what you get is what's called periodic breathing. So you start breathing heavier and faster to get more oxygen. You're blowing off all your carbon dioxide, and then your body says, hey, wait a minute, where's all that carbon dioxide going? And it stops your breathing. It stops it, okay? Because it wants to raise the carbon dioxide levels back up in your body. And then your oxygen level starts to drop because you're not breathing, and you start hyperventilating again. So you blow off all your carbon dioxide, and then it stops breathing. That is called central sleep apnea. It's not a problem that you're trying to get in air and you're obstructing your airway. It's just that you stop breathing. And here's schematically how that looks. Normal respiratory, even pattern, inhalation and exhalation. Here's the central sleep apnea. The hyperventilation in response to the low oxygen, the apnea, or no breathing for 10 seconds in response to the low CO2, hyperventilation again. Different form of apnea than obstructive apnea, but equally as dangerous. So eventually, everyone sort of acclimates to the altitude. You can't have this periodic breathing forever. So your body gets smart, and it says, okay, I'm going to reset my thresholds here. I'm not going to respond so aggressively at lower oxygen levels. So you reset that hypoxic response. You get more red blood cells. Okay, so that's why athletes like to train at high altitude because you increase the mass of your red blood cells to deliver more oxygen to the tissues. Your red blood cells get better at delivering oxygen to the tissues, so they can push the oxygen off the red blood cell into the tissues. You get more capillaries to diffuse it. And the gradients, biochemical thing, but the gradient which oxygen passes from the bloodstream down into the tissues gets higher, so it's easier to facilitate the oxygen delivery. So when I was reading through all the research, and I'm like, well, how am I going to explain to them how people's obstruction gets altered at the high altitude? I thought, well, maybe the best thing is just show you an example of someone that we treated. So this is a gentleman who's a little overweight, who had atrial fibrillation and irregular heartbeat. And I said, God, I can't really find any reason for you to have this. You don't have high blood pressure, you don't have heart valve disease, you've never had a heart attack, there's a family history of this. I'm like, why don't we put one of these pulse oximeters on your finger so I can see if it's abnormal? And it was horrible. So this is the pulse oximeter reports that we get from the oxygen companies. On the top you have heart rate, and on the bottom you have oxygen saturation. That's on the y-axis. On the x-axis is time. This top number here, for those of you in the back, is 90%. Your oxygen saturation should be at least 88% and above while you sleep. Well, you can see here, starts off bad, and then bam, it's horrible. Huge dip in desaturation. Again, big drop in desaturation. So these drops, to me, are consistent with the obstruction. Something's going on where his oxygen levels are plummeting, then he wakes up and recovers and develops another event. So I said, you got bad sleep apnea, we got to get this fixed. So I sent him to the sleep lab, diagnosed his sleep apnea, we got him a CPAP, we got him on the CPAP, battled him with the masks, did everything. 6-7 weeks later, I said, hey, let's see how we're doing. Still having the AFib. I said, I don't understand this. We treated the obstruction. I know the obstruction's gone. I pulled the information out of the machine. Your obstruction's not a problem anymore. Why are you still having the AFib? And I said, let's do another pulse oximeter and see. And I said, you gotta be kidding me. It's still low. I said, we fixed the obstruction. How is that a factor? Again, this one's a little different than the other ones. Oxygen saturation's on the top, oxygen saturation and time, but still consistently less than 90%. I said, I can't be. I fixed your obstruction. So I said, this has got to be something related to the altitude. It's got to be due to the air and the environment that you live in. So I said, let's bleed some oxygen in your CPAP. Let's put oxygen in there and take the altitude element out of the equation. And lo and behold, consistently over 90%, the AFib was gone. That is the best way I can explain it to you of how the altitude affects your sleep apnea. So, take-home points with that, the higher you go in altitude, the worse the central sleep apnea will be. If you have sleep apnea, say you were diagnosed down in the Bay Area and you've moved up here, chances are your sleep apnea is significantly more complex now than it used to be, both in terms of the obstructive events as well as the central events you experience. So it may not just be CPAP. You may need oxygen blend in as well. And sometimes we have to use other modes of ventilation, what are called BiPAP, which is like CPAP, but we give 2 pressures. And sometimes we have to use a BiPAP with a backup ventilator, which breathes for the patients during these central sleep apnea episodes. So what do I see in the office? Well, I think one of the number one things is high blood pressure. Your blood pressure should be less than 140 on the top and 90 on the bottom. Almost half of the patients who have sleep apnea have high blood pressure. And up to 30% of the patients that come into my office for high blood pressure have undiagnosed sleep apnea. The worse your sleep apnea is, the worse your blood pressure is going to be. It's almost in a linear relationship. If you have severe sleep apnea, you're 3 times more likely to be hypertensive. And they call hypertension the silent killer because you don't have symptoms until you manifest the clinical disease, which is either stroke, heart attack, peripheral vascular disease. The biggest thing that I see is in the resistant hypertensive people. The people that come to me from their primary care, they're on 4 blood pressure medicines, they're 150 over 90, and they can't get it controlled, they want me to help. I'd say at least 70% of those people have sleep apnea. And treating those people, I can bring down the blood pressure and minimize the amount of medication that they need to take. Now, if you're on 1 or 2 blood pressure medications and you have sleep apnea, that doesn't always work the same way. I can treat your apnea, which is important, but I can't always peel those people off medications. But what about heart failure? Heart failure is this clinical diagnosis where the heart is not functioning to pump blood to the body. Well, can sleep apnea cause heart failure? A gray relationship, not well documented. But what I can tell you is those bursts in those catecholamines, that spike in your blood pressure at night, that increase in the pressure gradient in your chest, can thicken your heart. It can thicken the heart muscle. And when your heart muscle gets thick, it doesn't relax as well. It has to fill with higher pressure to distend it, to pump the same amount of blood forward. That higher pressure backs up into your lungs and causes a form of heart failure. Not all heart failure is that you had a big heart attack and your heart doesn't squeeze. Heart failure can occur in a normal squeezing heart. It just can't relax as well as it used to. In people who have heart failure, so you've already been diagnosed with heart failure, if you have moderate to severe sleep apnea, that dramatically increases your mortality. And worse is we're trying to treat someone's heart failure. They have this bad heart, they had a big heart attack. We're trying to improve the heart function to get their prognosis as good as possible. And we're putting them on all these medications to do it. Every night they get apneic. When their oxygen levels drop, their CO2 levels go up, they get this inflammatory response. Their blood pressure skyrockets. It puts all this stress on the heart. It's totally counteractive to what we're doing all day long with the medication. I screen all my patients with heart failure for sleep apnea. Now what about stroke? Okay. This is actually a really hard one to define because most of the people that get referred for sleep apnea studies have already had a stroke. And when you have a stroke and you affect your brain, there is a high percentage of sleep apnea that occurs from that. Classically, there are 2 main groups that get central sleep apnea. Those who have heart failure and those who have had a stroke. The only real good research I can find as to sleep apnea as a primary cause of stroke is there was a Japanese study where they MRI'd brains of people who had sleep apnea that had never been diagnosed with a stroke. And they found that in 25% of those people, there was MRI evidence of a stroke that they had no idea about. Well, what about arrhythmias, abnormal heart rhythms? This is probably the most common cardiovascular side effect. Occurs in about 50% of the people. And if you have severe sleep apnea, you're 2 to 4 times higher at risk for developing some type of heart rhythm abnormality. And some of these can be extremely dangerous, such as a series of rapid beats coming from the bottom chamber of your heart, called non-sustained ventricular tachycardia. You can have pausing or discommunication between the top and the bottom part of your heart, and you can have what are called Pvcs, which are extra beats coming from the bottom chamber of your heart. Pvcs are incredibly common and related to untreated sleep apnea. So here is an example of an EKG that was obtained during a patient with a sleep study. You can see they've already got sort of a slow heart rhythm, and then they become apneic. And then you have this long period here of no heart rhythm, nothing. And that is called asystole, which can be found in people with severe sleep apnea during their studies. Well, why does that happen? Why does your heart rhythm pause? Shouldn't it go crazy because you get all these catecholamines and you're jacking up your blood pressure? Why doesn't your heart rate speed up? Well, here, let's look at this. This is a schematic sleep study. So up here is your oxygen saturation. Well, let's start here with your breathing. So you're breathing, you get apneic, okay? No breathing. Oxygen saturation drops. No airflow going through your nose. Heart rhythm, bradycardia. Compensatory bradycardia here in response to the apnea. This is called the diving reflex. Okay? So what happens is when you generate this huge negative intrathoracic pressure, it sends a big bolus to your heart of what's called a vagal tone, which slows down your heart rate and disrupts your electrical communication. So the slow heart rhythms, the slow heart rates, the bradycardia, the asystole, are the most common electrical disturbances related to the sleep apnea. That asystole can last for up to 10 seconds, which is a long time. If you have asystole for 5 seconds and you're standing up, you're passing out. The coolest part about this is there's all these people that come in for these slow heart rhythms that need to be referred for pacemakers. And I can't find anything wrong with them. I say, I don't know why you have this slow heart rate, but you're symptomatic, you need to put in a pacemaker. 60% of those people have untreated sleep apnea, which is causing their bradycardia. So many electrical doctors say, hey, before you put a pacemaker in this guy, let's check him for sleep apnea, because if you treat the sleep apnea, you may make his bradycardia better and he doesn't need a pacemaker. And these people have normal electrical systems. It's not that the electrical system's diseased. They haven't had a heart attack and have damaged their electrical system. They're normal. It's just this neurologic response to the sleep apnea. Well, what about another rhythm called atrial fibrillation? So on the left is a normal heart's electrical system. Okay, so this is the top of the right heart, the right atrium that contains your sinoatrial node, the natural pacemaker of your heart, which transmits electrical activity down to your AV node between the atrium and ventricles, and then passes down into the ventricles, the main pumping chambers. So it's a rhythmic process. Top chamber squeeze, bottom chamber squeeze, top, bottom. In atrial fibrillation, you lose that. And you develop this chaotic, irregular rhythm that causes the top chambers to fibrillate at rates of 400 to 600 beats a minute. Well, what causes that? Well, you drop your oxygen level, you develop that increased interthoracic pressure, which puts stress on the atrium, you shoot up your blood pressure to 240, that causes dysfunction of the electrical system and triggering of the atrial fibrillation. Well, what about coronary disease? Blockages in heart arteries, probably the most common thing we see in cardiology. Well, if you have sleep apnea, and you're 2 times more likely, coronary disease is 2 times more likely in patients with sleep apnea. We used to do this thing called coronary calcium scores. Everyone's trying to detect coronary disease, and no one wants it to manifest as a heart attack. You're trying to screen for it every way you can. And we used to do CAT scans of the chest and look for calcium in the heart arteries, and the calcium would be sort of a surrogate marker for cholesterol plaque. And they'd sum up how much calcium you would have and compare that to normal individuals and give you a risk. Say, gosh, you got more calcium than 90% of the people your age, and you'd say, oh, I gotta do something different here. So when they do this coronary calcium scoring for people with sleep apnea, we find that they have much higher scores. Independent of other risk factors, independent of diabetes, hypertension, smoking, family history, obesity, sleep apnea, higher coronary calcium scores. Like I said earlier, chest pain at night, frequently caused by sleep apnea in patients with coronary disease. I always treat my severe sleep apnea patients with coronary disease, because if you don't, they are at markedly higher risk for recurrent heart events, stroke, heart attack, or death. So where do we go from here? What's the next step? Well, I would tell you, if you're already diagnosed with sleep apnea and you're on a CPAP, you should be making sure it's working for you. So all of our patients, at least on an annual basis, we do 2 things. I measure their oxygen saturation overnight with a pulse oximeter, and we pull the data out of the machine. These CPAPs have chips in them. They're recording chips. And it tells you all kinds of information. Number 1, are you wearing it, which is always nice to know. Number 2, how long you're wearing it for, which is important for people with Medicare. Number 3, what pressures you're using. How much pressure is it taking to keep your airway open? And number 4, what is that apnea-hypopnea index? Have we taken it from 30, which is severe, and brought it down to less than 5, which is normal? The suspicious symptoms I would want you to recognize: snoring. If you got a spouse that snores, have them get screened for sleep apnea. If you see them stop breathing at night, choke, gasp, roll over, start sleeping again, another suspicious sign. All of the primary care physicians at Barton know how to refer you to a sleep study. They know about the home sleep studies. So you can get into any of your primary care doctors. I'm sure they can get this handled. Where I get interested in is if you're on more than 3 blood pressure medications, you're getting chest pain at night, you've got an inappropriately slow heart rhythm during the day, and you're waking up at night with palpitations. Those are the ones I want to see personally. The weird part about sleep apnea, and I'm learning this, is no one really knows a whole lot about it. And it's kind of a, people joke, he snores, so that's no big deal. Well, it's actually a really big deal. So there's a lot more research that needs to be performed in this area. I truly believe it's an underdiagnosed disorder, particularly in this patient population here in Tahoe. We need improvement in therapy. There's got to be something better than these masks that blow air in your face and dry out your mouth and cause nasal congestion. There's got to be something better to treat this. Remember, only 50% of the people are compliant with this. We've got to do a better job as physicians as treating this. Treatment can make huge changes in people's lives. And I'm not just talking about the hypertension. I'm not just talking about the reduced rate of stroke or coronary artery disease or heart rhythm abnormalities. People feel like new people. You have better moods, not depressed. You have more energy. You breathe better. I remember there was one older gentleman that came in, and he was just a zombie. Just a zombie. And he had this horrible sleep apnea. And so we treated it. And he bounced in the office. He comes jogging in. His wife says, "What did you do to him? I can't keep up with him now." So it can make huge changes in people's life. Please, please. It's not a laughing disorder, the snoring. Anyone you know that is snoring, please get them screened. And I hope that broadens your information about sleep apnea. I'd be happy to take any questions.
Is it hereditary?
Depends. I do not know about a specific genetic inheritance pattern of sleep apnea itself. Obesity, yes. Anatomical anatomy of the airway, probably. Jaw features, tongue features, crowded neck. So I would say that part of it is genetic. But honestly, I don't know about some pattern of inheritance specifically related to the sleep apnea. One of the hard things about sleep apnea is you see it in people with other cardiovascular conditions. So it rarely occurs as an isolated disorder. You have people with high blood pressure and sleep apnea, people with stroke and sleep apnea, people with heart failure and sleep apnea. So it gets really hard to sort of separate everything else and primarily focus on just the sleep apnea itself. And I think that's been a very limiting factor to the research that has been able to be performed.
Does it get more intense as you get older?
Yes, of course. It gets worse with age.
Okay.
Okay. Worse with age.
Yeah,
She just got signed up for a sleep study. Yeah, we should.
So what do I do?
Just call us and let us know. We'll get it set up. Yes?
Counterpart changes such as picking nipple or whatever, and you're put on CPAP. Does your heart conduction normal?
Not known. It's not known. Okay, so when your heart thickens, some of the changes is muscle, but some of it is like a fibrotic tissue. It's like a scarring tissue that occurs. That part won't fix. The muscle part could regress. Okay, that occurs in response. Like when athletes do a lot of training, they get thicker heart muscle, but it's normal heart muscle. It's in response to the training, and when they stop training, it goes back to normal. So that part I can imagine. The scarring that occurs, that doesn't go away.
One more question.
Yeah.
People who are going to have surgery that have a diagnosed sleep apnea.
Yeah, that's a big problem. Yeah, because so what happens is you get this anesthetic when you have surgery, which worsens your sleep apnea. And then you go home from your surgery and you're on pain medicine, which flares your sleep apnea. So Barton they're developing a new program, which I think is called Stop Bang, where they're screening everyone prior to an outpatient procedure for sleep apnea. And they're sort of fine-tuning how you want to do it, because you really want to catch the high-risk people. If you have mild sleep apnea, it'll probably do just fine. But if you have severe sleep apnea, well, you want to get that treated before you can go on to surgery. So that is a big deal. And an upcoming deal across the country is people recognize more the bad outcomes that you get from sleep apnea, particularly in post-surgical setting. There's a question over there, Ken.
Relationship to secondary pulmonary hypertension.
So in response to the pulmonary, so we asked about pulmonary hypertension. So pulmonary hypertension is a clinical disorder where you have increased pressures in the arteries in your lungs. So the right side of your heart pumps blood into the lungs. Pulmonary hypertension can occur in response to what we call hypoxia, which is low oxygen levels. So people with pulmonary hypertension can have it develop from sleep apnea. What I think is less unclear is treating the sleep apnea if it leads to decreasing your pulmonary artery pressure. And when he's talking about primary versus secondary, primary pulmonary hypertension is sort of an idiopathic disorder, which means we don't know what causes it, of the lung arteries itself, where they scar down and narrow, whereas secondary is due to something else, like chronic obstructive COPD, smoking, autoimmune disorders, left heart failure, etc. So I don't think there's a lot of clinical evidence that supports that you treat the apnea, the pulmonary hypertension gets significantly better.
What about the relationship to mitral valve?
Or regurgitation or stenosis.
What is secondary pulmonary hypertension?
Well, so you're probably talking about, so the mitral valve is on the left side of your heart. It separates the left ventricle from the left atrium. And you can really get two abnormalities for that, which can either be regurgitation where it leaks, or you can have stenosis where it narrows. That was a common consequence of rheumatic fever, which we don't see much anymore. So yes, abnormalities of your mitral valve, which lead to back pressure and congestion of your pulmonary vasculature over time, can cause scarring of the pulmonary arteries, which can cause pulmonary hypertension, which will not be reversed with treatment of sleep apnea. The scarring that occurs there is a permanent disorder because the artery gets thicker and thicker in response to the high pressure.
What about the relationship to repair?
So that's different. So that's regurgitation, where you have something primarily wrong with the valve apparatus that is repaired. And the pulmonary hypertension that was induced from the prior regurgitation, I don't think that's reversible. But certainly it won't get worse as you repair the valve and eliminate the regurgitation.
A question. A friend that had his driver's license revoked.
Yeah.
He didn't fall asleep during the day. Never seen him take a nap at 3. Why is the medical association taking driver's license away? And do you think that's scaring people from even being checked?
Well, there's only a few instances that we're medically required to take away someone's license, and in my field, that's someone that passes out. So if you pass out and there's no clear cause, then you have to take away someone's license until you get the issue solved. And that could be a seizure, that could be a cardiac rhythm disorder, it could have been a stroke, whatever it is. If you pass out, your license gets taken away.
He was only diagnosed with severe apnea, but never passed
Yeah.
out.
Well, someone must have seen him fall asleep at the wheel or something and reported him.
Wow.
Because that's classically what happens is, people get this severe sleep apnea, you're not sleeping at night. I mean, you go to bed, you snore, you obstruct, you're up. You snore, you obstruct, you're up. So you have this fragmented sleep, so you're just chronically fatigued. And you get to a traffic light, it's a nice summer day, it's warm, the sun's hitting you, and you fall asleep. And that's how you get your license taken away.
So there's no danger of losing it if you're just diagnosed with
No,
severe
absolutely
apnea?
not. Absolutely not. Yes?
I saw the Kingsbury versus Lake Tahoe
Yeah.
slide. So during like a high pressure and a low pressure storm,
They'll change.
You snore more during storms?
Well, I don't know about the snoring, but there's certainly less atmospheric pressure during a low pressure system, so that will drop the oxygen concentration. I actually thought the same thing when I was learning this. I was like, wow, what happens during these storms when the low pressure comes in? Well, there's less air. There's less air, there's less pressure. Okay, so there's less oxygen. So I don't think it'll make you snore more, but it certainly could make the apnea worse, particularly if you're a central sleep apnea person. Yeah.
If you have been diagnosed with sleep apnea due to the tonsils,
Yes.
and you're gonna remove them or have surgery, are there any risks of having the tonsils taken off during
well,
adulthood?
Pain.
Yes, pain.
So usually pain. So most of the people don't just get their tonsils taken out. The surgery, I can never pronounce the full name. It's like uvulopalatopharyngoplasty. I just call it the UPPP because it's shorter. It hurts. Okay, it's really painful if you ask people that have had it. You know, they usually, they go in, they take out your uvula, they take out the tonsils, the adenoid, they resect some of the posterior pharynx to sort of carve out as much tissue as they can there to open up the airway. So I don't know of any consequence. And again, I'm not the world's sleep apnea expert. I'm just telling you what I've learned from cardiology. But I know people, it hurts. It really hurts for a period of time, and they do. It's hard post-surgically because you just can't breathe. You feel suffocated. My dad had it done. He had a miserable time for the first couple of weeks. And it doesn't fix your apnea all the time. I have plenty of people who have had the procedure, and yes, their apnea has gotten better, but they haven't gotten off CPAP. So I think that's always something, if you have bad apnea and you can't tolerate the CPAP, then, well, certainly that's something to consider along with the mouthpiece and maybe wearing oxygen. But for most people, we try the CPAP first before we press on with that.
The mouthpiece.
Yeah.
The solution. Doesn't seem to be very common in this course.
Yeah. I think some of the dentists in town make them. I've tried it in a few people, and it hasn't really worked well for me and the patients that I've used. And if it's just a problem with the mandible and shifting the jaw forward, well, that would make structural sense. You move the jaw forward, it opens up the airway. But if it's a problem here, it's not really going to work if you move the jaw forward. But I think some of the dentists in town will make a mouthpiece for you if you set up an appointment with us. I don't know. How's you mean?
Yeah.
Guys in town. So, I know some
We
of
have a
them.
dentist here.
So,
Say.
do you make them, or do you know other people in town that do them?
I retired people, but I made them for patients.
Yeah.
Other patients work really well.
Yeah.
Other patients can't tolerate things to come out.
Yeah.
So it depends. It's like some patients have a hard time with CPAP.
Yeah.
But we have some patients that just love it.
Yeah, I can imagine if it's because you have a setback jaw and you got
Except the jaw, bottom jaw.
yeah,
lower,
yeah,
And if they can sleep that way, that's fine.
yeah, just sort of bring the jaw out.
Yeah.
Yeah, that's about what I witnessed too. Yes.
So alcohol consumption's an issue. How about diet?
So as far as eating sodium-rich foods, carbohydrates, outside of making your weight an issue, I don't know that directly affects your apnea. And the alcohol is just because it's a central nervous system depressant. Okay, and it relaxes. That's why everyone snores when you're drunk. You just relax your airway, you snore.
So not tryptophan and turkey?
I don't know about that. I don't think so. I do snore probably after Thanksgiving. Yeah.
Is there an end to wearing a CPAP?
No, there's no end. That's a lifetime process. And unless, of course, you have mild sleep apnea because you're obese and you lose the weight, you fix the mild sleep apnea, but otherwise, no. That's why it's so critically important to get it right in the beginning. And there's two ways. My own little nuances is they used to do what are called split night studies. So you try and do the whole thing in one night. You go in, try and diagnose it, and fit you for CPAP, and get it all right, and then send you home. And I said, no way. Don't do that to any of my patients. It's so hard to diagnose. I always have them do a full night study just so I know what the problem is. What are we dealing with? And then you also got to spend a whole night just trying to fix it. What pressures do you need? Do you need a CPAP? Do you need a BiPAP? What mask fits your face? Are you a mouth breather? Because if you don't get it right in the beginning and you don't get the right mask and stick with the people and get the pressures right and work with them, it's done. They'll never use it. So it's critically important to get it right in the beginning.
What happens if you're a tummy sleeper?
Yeah, well, that's a problem because people, you roll over, you knock your mask sideways. You have to adjust. There is a definite adjustment in your sleep pattern to use this device, and that's why 50% of the people can't take it.
What about change of altitude? If you go down in elevation, you have to
Crazy differences.
You have to reset the pressure.
No, well, so there's two types of CPAPs you can have. A lot of CPAPs are fixed pressure. Okay, so they'll say, okay, you're getting 10 centimeters of water blown in. I never order a fixed CPAP pressure. Most of the devices now are auto CPAPs, so you can give them a pressure range. You can say, I want it to go from 6 to 14. So that way, if you go down to San Francisco, you maybe only need 6, okay? You're in deep REM sleep at 7,000 feet, you may need 14. So most of the devices now can vary the pressure that you need based on the severity of your apnea.
Do they self-regulate, or do you have to set it?
They self-regulate. So we set the pressure range. And, you know, the Philips guys came to explain to me the complex algorithms, how it works, but I think it sort of pushes in a pulse of air and measures the resistance in your airway that it's getting to determine how much pressure it needs to adjust to. But yes, the sleep apnea at lower altitude will be significantly less complex and lower in pressure required to treat it than high altitude. Yeah.
Are apneas worse during sleep?
Yes, because when you're in REM sleep, your body's paralyzed. Okay, that's your dream sleep. Okay, and although your mind may be going crazy, your body is paralyzed. That's when you have the least muscular tone, and that's when the airway tends to collapse the most. Okay. I just saw someone study today that they said, well, look, it's only mildly abnormal. I said, yeah, but you didn't go into REM sleep the whole time you were there. Who knows? It could double in severity. So REM sleep is when you tend to have the worst apnea.
Is there a sleep specialist, expert partner who just concentrates on apnea?
No. Yeah, that's me by the default right now. They're working on it. And I have been chirping in the air to make that happen because I think that we need one. There is a pulmonologist, well, there's several pulmonologists sort of in the area that manage sleep apnea. The one that Barton's been working with is named Greg Trudell. He's a doctor in Truckee who's been helping sort of supervise the sleep lab. But I'm hopeful soon that we'll have a pulmonologist that can help manage this. Okay. Oh, yeah, we have one more.
One more. Should you go back in after a couple years of wearing a mask to do a full nighttime sleep and all?
That depends. I think if you get your compliance data, the data out of the machine, and your oximetry, and if those are abnormal, or if you're developing recurrent symptoms, or if you just moved here from a low altitude to high altitude, yes. If you got a mask that's working for you, your compliance data looks great, your oximeter's great, no reason to. What? Oh, well, she was asking what happens when you go to sea level. And I really tell people that depends on how severe your apnea is, because no one wants to carry this thing on their luggage when they travel. If I have people that sort of have mild, maybe moderate sleep apnea, I'll turn my cheek while they travel to a low altitude. If I have people that have severe sleep apnea, I tell them you're stuck, you gotta take it. And the machines really aren't that big. It's, you know, it's kind of a shoebox looking thing, so, and most people just pack it in their carry-on. You gotta let the TSA guys know you got a CPAP in there so they don't think you're a terrorist, but most people can travel with it. The other thing I will see is a lot of my patients who are on CPAP or BiPAP have bleed-in oxygen because of the altitude here. Rarely does that need to go with you. Okay, so you may have to take your CPAP or BiPAP, but the oxygen concentrator that's used to bleed in the oxygen, I don't have people take those to low altitude.
Isn't your manufacturer usually small, portable?
Yeah, I saw those in the Sky Mall when I was flying last time. Yeah, they have like a travel-size portable CPAP, and I have no experience with that to know how effective it is, but I do know that they make smaller units.
I have a friend who has one, his friend's one.
Yeah.
He travels a lot, and his brother says it's small in his hand.
Yeah. Well, I think part of the problem you're going to run into is your insurance company as well. I mean, if you want to purchase these machines for your own good, that's totally up to you. But I don't know if Medicare or everyone. Most of my patients have Medicare, so I'm really limited, unfortunately, in what I can get. Well, thank you. Thank you for coming.